Welcome to the October 2024 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. My name is Mike Rickels from the University of Pennsylvania.
And I'm Alice Cheng from the University of Toronto, and we are your co-hosts for this podcast series.
As per usual, Alice and I will interview authors of the feature articles selected by the editorial board of Diabetes Care, and then follow up with our rapid exchange segment where we discuss some of the articles we found of particular interest.
And before we do that, as you all know, it is October, and for those of us in the Northern Hemisphere, it is getting colder. The leaves are changing color and starting to fall, and at least for us in Canada, October also means the Thanksgiving holiday. Now, Thanksgiving is all about gratitude and giving thanks for what we are lucky to have. I, for one, am thankful to be part of this team with you, Mike, and for being part of the larger diabetes community as an American Diabetes Association member. And in the spirit of sharing that with others, Mike, do you want to tell our listeners about a very special promotion on now for new and renewing members to the ADA?
Well, I see what you did there, Alice, and very nice segue. I too am very thankful to have this opportunity to work with you on diabetes care on air and for the ADA to mention the special offer exclusively for new and renewing members that is available between now and November 30th of 2024. So also extending through our Thanksgiving holiday in the United States. And when you sign up for or renew your professional membership to the ADA, use the code FALL24, FALL24, during checkout, and you'll receive 15% off the yearly membership price. And if you sign up for a 2-year membership, you'll receive a 15% discount and a free It Takes All of Us shirt from the ADA.
All of the ADA membership benefits, like member-exclusive discounts to conference and other CME events, subscription to an ADA journal of your choice, copy of the Standards of Care in Diabetes, and access to webinars, is frankly enough to make anyone want to join or renew their membership. But now you add an awesome red t-shirt to the pot. Who can possibly resist?
ADA membership is one of the best ways to gain access to an international community of professionals who share your passion and dedication in the fight to end diabetes. So if you've been considering joining the ADA or renewing your membership, now is the perfect time. Remember to take advantage of this offer by going to professional.diabetes.org/membership and use the discount code FALL24 to get 15% off a 1 or 2-year membership. And remember, 2 years gets you the shirt, and this offer expires November 30th, 2024.
So don't miss out on this opportunity to expand your commitment in the fight to end diabetes by joining the American Diabetes Association. And if I were you, I would totally pick the 2-year option to get the t-shirt. And maybe, Mike, we can be in matching t-shirts next time we see each other.
Let's do it. And on that note, Alice, let's dive into the October 2024 issue of Diabetes Care.
One of the feature articles from the October 2024 issue of Diabetes Care is a narrative review that addresses a growing clinical concern entitled Incretin-Based Weight Loss Pharmacotherapy. Can resistance exercise optimize changes in body composition? I'm pleased to be joined by Professor Yeap, endocrinologist, professor in the Medical School, University of Western Australia in Perth, Australia. Thank you very much for agreeing to be part of this podcast, and congratulations to you and your colleagues for completing this important review and being selected as one of the feature articles for this month's issue.
Right, thank you, Alice. Speaking on behalf of all my co-authors, we are very excited to have Diabetes Care publish this review, and we are also very happy to be part of this podcast, so thank you.
Thank you. So incretin-based therapies, such as GLP-1 receptor agonists and dual GIP GLP-1 receptor agonists, have proven to be incredible game changers in the treatment of type 2 diabetes, overweight, and obesity in terms of their metabolic benefits, as well as cardiac, kidney, and other benefits. And looking into the future, there will be more such therapies with multi-agonism of what I like to call GLP-1 and friends, such as amylin and glucagon and others. All of these have in common an important impact on body weight reduction that was difficult to achieve outside of surgery, which really has been wonderful from a clinical perspective. But we're all starting to ask the question of whether or not there is, quote unquote, too much weight loss. So please share with us why you and your colleagues decided to undertake this narrative review.
Clearly, the incretin-based approaches provide very effective anti-obesity pharmacotherapy. And yes, they are absolutely game changers. So with these medications, we might actually take away the need for bariatric surgery in some people. Now, to some extent, patients could be protected from losing too much weight because the rate of weight loss does tend to slow and plateau after time. And weight loss is something that we can measure quite easily, so we can actually monitor it quite carefully. And we can discuss with our patients ahead of time what their treatment goals are, and we can modify the treatment or dose adjust appropriately. So weight loss is something we can track and monitor during treatment. But the reason we wrote this review was to highlight that it's the change in body composition that needs to be considered, not simply weight loss on its own. So losing excess weight is highly beneficial if it means losing a lot of fat, particularly the central adiposity. But what might be undesirable is losing too much lean mass or muscle mass. So when we think about using GLP-1 receptor agonists or the GIP-GLP-1 dual receptor agonist, we also need to think not just how much fat is being lost or how much weight is being lost, but also how much lean mass or muscle might be being lost as well.
So my understanding, as you've alluded to, is that weight loss is usually associated with loss of both, of fat mass as well as non-fat mass. And within the non-fat mass, that could also include muscle mass. So why does it matter to lose muscle? And do incretin-based therapies have a different impact on muscle loss compared to just general weight loss for other reasons?
Well, interventions which result in weight loss or dramatic weight loss typically induce loss of both fat and lean mass. And that lean mass includes muscle mass. And muscle mass is important. I mean, we know it's important for movement, locomotion, strength, but it's also a major site of glucose utilization. It's metabolically beneficial. And there is a risk, particularly in older adults, that losing muscle mass might predispose to future frailty. So in our review, we looked at the effects of different incretin-based therapies on weight loss in the context of obesity. And with the newer GLP-1 receptor agonists or the GIP-GLP-1 dual receptor agonists, and now with the GIP-GLP-1 glucagon triple agonists, I mean, these medications result in dramatic weight loss. So 15, 21, even 24% of total body weight in people with obesity. And when we look at the published data closely, both fat and lean mass are reduced. So in the subset of participants which have had formal studies, for example, with DEXA done, in step 1, with semaglutide 2.4 milligrams weekly, over 68 weeks, there was an average loss of 10 kilos of fat mass and 7 kilos of lean mass. And in SOMAT1, with tirzepatide, 5 milligrams, 10 milligrams, or 15 milligrams, 72 weeks, over that period of time, on average, there was a loss of 17 kilos of fat mass and 6 kilos of lean mass. So the incretin-based therapies do result in loss of both fat and lean mass, and that lean mass will include muscle mass.
So then let's talk about exercise then, right? So, I mean, I assume that exercise has got to be good for muscle mass. So are there specific factors that impact the effect of exercise on body composition when one is losing weight?
Yeah, obviously exercise is good for lots of things. So, my colleagues at the University of Western Australia have shown that a combination of aerobic and resistance exercise improves cardiorespiratory fitness, it reduces fat mass, it increases muscle mass and strength, and it can do this quite promptly. And targeted resistance exercise, for example, using weights, is really best for preserving or building muscle mass and strength. If you can do that, even if your overall body weight stay roughly the same, you'll still benefit from having less mass and more muscle and strength, which is what you can do with resistance exercise. So in previous studies from UWA, we found that resistance training increased lean mass more than aerobic training, and that there are benefits of incorporating resistance exercise in older men with low normal testosterone concentrations. other studies have shown that both younger and older adults have improvements in lean mass with resistance training. And there is some evidence that perhaps younger adults might have a slightly larger effect, but both younger and older people will benefit. And there has been a fairly recent systematic review and meta-analysis of adults with obesity and overweight, and that shows that both females and males will improve muscle strength with resistance training.
So it sounds like resistance training is a good idea. So then here's the million-dollar question. So can exercise training, particularly resistance training, preserve lean mass and function in those taking incretin-based therapies?
So that's a really good working hypothesis, but there hasn't been a precisely targeted study to directly address the question. We know that exercise training, particularly resistance training, increases muscle mass and strength in the general population. In previous studies of adults with overweight and obesity who are having dietary interventions, resistance training does tend to protect against loss of lean mass. So this needs to be formally tested in clinical trials with incretin-based therapies. And we know that other measures like maintaining a decent protein intake are also likely to be important. But from the available evidence, we believe it's quite likely that resistance exercise would be beneficial when we use incretin-based anti-obesity therapies. The caveat here, though, is that the exercise program has to be, well, should be personalized, and it has to be delivered safely and effectively. So my co-authors on this review, we are in the mix of exercise physiologists and endocrinologists, and we need to ensure that people not only do the exercise, but they do the right exercise. We think this is actually going to be really important for the future of chronic disease prevention and including obesity management. This needs to be multidisciplinary. We should have exercise physiologists involved.
Now, if this pans out, and it sounds like it likely would, that adding resistance training, adequate protein intake will help some of that lean mass preservation, can that also impact the rebound weight gain after one discontinues incretin-based therapies? Because life happens and sometimes people have to stop for a variety of reasons. So can this be somehow protective?
This is a really interesting and a really important question. And this is something we've highlighted and expanded on in the review. And yes, rebound weight gain is an issue. So the studies have shown that when people stop the incretin-based therapy, they can regain up to 2/3 of the lost weight over a course of a year. So this is a major issue. Now, supposing we implement an effective resistance exercise training program at the start, and then over time, we'd expect to see substantial weight loss and fat loss. Now, if with exercise training we can protect or even increase the muscle mass, then this should actually enhance fat loss during treatment. And it should also decrease fat regain when we discontinue. And the reason is that if you keep your muscle mass, then you have more metabolic energy expenditure after you stop the treatment and the food intake begins to increase again. Now, it would be even better if the exercise, the resistance training becomes an ingrained habit and you continue to do it after you stop. And then that person might have the best chance of maintaining a really healthy lifestyle and mitigate the weight regain in the long term.
And that's always fantastic to see when we do see that in the clinic, right? When someone starts incorporating a physical activity regimen of some sort and then enjoys it, most importantly, and then maintains it. So what are some of the other research questions that remain to be answered on this topic?
I think there are lots and lots of research questions to be answered. So, we need to prove that this will work. And we really need to examine closely how resistance exercise interacts with incretin-based therapies, how exactly it modulates not just body composition, but other measures of health. And we then need to determine what are the optimal exercise programs and how long should we apply them. And we should need to do this across different population groups. So yeah, there's a lot of work to be done, but this is going to be really, really exciting.
So bottom line, what's the main practical message that you want our listeners to take away?
I guess the main message is that this is a fantastic opportunity for healthcare providers and exercise physiologists to work together. We can prevent, we can manage potentially a lot of the chronic disease that's associated with overweight and obesity. Now, we know that exercise has multiple health benefits in the general population, and we know that some of these benefits are particularly important for people on incretin-based anti-obesity therapy. So these medications, the incretin-based therapies, they have changed the game, and we want the best result for our patients. And facilitating resistance exercise training is something that we can do right now. So I think that's the message. We don't want to wait. We want to get onto it and try and get the best possible results for our patients.
Excellent. Thank you. Those are excellent messages. And I think it really reinforces, as you know, the 2022 ADA-EASD consensus statement within one of their 5 S's for 24-hour behaviors that can impact outcome. One of the S's is strengthening, right? So I think that really fits very nicely into the message that you and your co-authors are giving us. So thank you. Thank you very much, Professor Yeap, for sharing your expertise with us today. And again, congratulations to you and the rest of the team for this important narrative review. And I encourage our listeners to take a look at it. Exercise has always been important for health, but particularly in this population on incretin-based therapy. So we need to be encouraging resistance training. So thanks again, Professor Yeap, and I encourage our listeners to read the full document in the October issue of Diabetes Care.
In the October 2024 issue of Diabetes Care is a feature article entitled The Relationship Between Sensor-Detected Hypoglycemia and Patient-Reported Hypoglycemia in People with Type 1 and Insulin-Treated Type 2 Diabetes, the Hypo-METRICS Study. I'm delighted to welcome the article's lead author, Dr. Patrick Divilly. Dr. Divilly is a consultant diabetologist at St. Vincent's University Hospital in Dublin, Ireland. I'm so glad he could join us, Patrick.
Thanks so much for having me. It's a great honor to be selected, and it's great to be here today to be able to talk about this article.
Well, congratulations to you, Patrick, and your colleagues from the HypoResolve Consortium on this feature article. The Hypo-METRICS Study collected 10 weeks of blinded continuous glucose monitoring, or CGM, sensor glucose data while asking participants to report about any symptomatic episodes or, if they used a personal CGM, any technology alerted episodes of hypoglycemia. Can you tell us about the 2 cohorts that were studied and any important differences or distinctions between them?
Yeah, so overall in Hypo-METRICS, we recruited nearly 600 people living with diabetes, with about 321 living with insulin-treated type 2 diabetes and about 276 living with type 1 diabetes. So we had a pretty wide inclusion criteria because we wanted to kind of get people's lived experience. We weren't trying to exclude too many people from the study. But essentially, we were looking for both groups for anyone who had experienced some degree of hypoglycemia, either symptomatic or measured in the previous 3 months. And outside of kind of excluding people with very low renal function or those with automated insulin delivery systems, we really kind of included quite a wide basis of people from across the 9 centers that we recruited from in 5 countries. As you would probably expect, the type 1 population was a little bit younger, but they had a similar duration of diabetes to the type 2 population. There was slightly more women in the type 1 group. And again, maybe understandably, given the way the healthcare system is set up over here, a lot more CGM use in those living with type 1 diabetes than those living with insulin-treated type 2 diabetes. And even in between the 2 groups, whether they were on CGM or doing capillary blood glucose monitoring, the type 1 group did on average tend to test or scan or finger prick more frequently. And then the only kind of other caveat in the characteristics really was we did actually have similar levels of impaired awareness of hypoglycemia between the 2 groups. And that's in part because, I suppose, running a hypoglycemia trial in type 2 diabetes is probably going to attract a slightly more enriched population. So a little bit higher than what you would see maybe in your general insulin using type 2 population.
Great. And your study also observed more sensor detected and patient reported hypoglycemia among those with type 1 compared to type 2 diabetes in your cohorts, which also seems expected. But overall, 65% of sensor detected hypoglycemia was not associated with patient-reported hypoglycemia, and 43% of patient-reported hypoglycemia was not associated with sensor-detected hypoglycemia. So I'm curious whether this latter finding surprised you, and if you think the results might have been any different if, say, a Dexcom sensor were used rather than the Abbott Libre sensor, which clinically I feel tends to be more accurate in the hypoglycemia range, but just wanted to get your thoughts on that discrepancy.
Yeah, I think to answer the second part of that question first. So, while we were the kind of first to use this methodology and to look at it in both type 1 and type 2 diabetes, there's a couple of other studies out there that really do point to this kind of discordance between these two measures of hypoglycemia, and they've used different sensors. So, if you look at the kind of in range study where you're comparing insulin glargine 300 versus insulin degludec, and that was using a Dexcom sensor. Again, you were seeing a much higher proportion of sensor detected hypoglycemia than you were being seen person reported hypoglycemia, and in similar ish percentages to what we saw in our study. Now, they didn't match those events because of the methodology that they were using. But again, that was quite consistent with the Dexcom sensor. There's been other studies done in Denmark in type 1 diabetes using Medtronic sensors, which again have shown about 60 to 80% of sensor hypoglycemia is asymptomatic. And even for capillary blood glucose monitoring, other small studies done in the early 90s in Denmark would show actually that the discordance when using kind of multi-point, 7 times a day capillary monitoring, plus the times when people are symptomatic, shows that that discordance is even wider again. So I believe this is very much, a real phenomenon and is not necessarily sensor specific. It may have a small impact on it, but I think it's very much a genuine phenomenon. We were a little bit surprised with the amount of hypoglycemia reported outside of these hypoglycemic ranges. We've obviously explored this and we've looked into it. We didn't see an association with mean glucose or A1C as we would have thought. Those with higher A1Cs may be more likely, to report hypoglycemia outside of hypoglycemic ranges, as the CLAMP studies would have shown us before. And we have looked, because of the way the app worked, where not only did people report hypoglycemia, but they could report details and symptoms and intensity of hypoglycemia. We have actually looked at these kind of unmatched episodes versus the matched episodes. And what you see there isn't really any difference in terms of the amount of autonomic symptoms that are reported, but you see a lot less neurogenic or neuroglycopenic symptoms reported in that unmatched group. So it may well be the case that some of these episodes are responsible because of some degree of sensor inaccuracy. There may be other factors in people which kind of stimulate a hypoglycemic response that maybe we don't fully understand. And also in a small proportion of people, maybe they're genuinely reporting autonomic symptoms, but they may have a different underlying cause.
Now, the proportion of sensor-detected hypoglycemia associated with patient-reported hypoglycemia was higher for the cohort with type 1 diabetes than the cohort with insulin-treated type 2 diabetes. And you mentioned already there was more CGM use, greater frequency of capillary blood glucose monitoring in those individuals with type 1 diabetes. Might that be explaining an opportunity for technology detection in the cohort with type 1 diabetes that is being documented as a patient-reported event and hence matching with the sensor-detected measure? Do you think that may be explaining some of the difference in the two cohorts?
Yeah, so I think the way you were thinking was our hypothesis when, certainly when I saw this data, that was my first thought. And also there might be some factors in terms of the age discrepancy between the two groups. So we did actually go on and do a further analysis, which is included in the paper here, where we controlled for age, for CGM use, for gender differences and rates of hypoglycemia and impaired awareness of hypoglycemia. And we still saw a pretty significant discrepancy between the two groups. Now, that doesn't account for frequency of testing, but I think that is, reflective of what happens in the real world, that, people test at different levels. So I do think that CGM use and the testing may in part explain some of the differences we're seeing. But, when we look at it on a symptomatic level as well, we see kind of similar divergence between the type 1 and type 2 group as well. So even if you get rid of those technology hypos, you see a similar percentage difference. And it may be, as I said, a variety of factors. It could be some comorbidities, medications that people living with type 2 diabetes are using. But I do think I kind of support, I think the point you're trying to make as well, that I think it does support the use of CGM in people with insulin-treated type 2 diabetes. I think it reveals a lot more hypoglycemia that maybe we thought that, the patient was telling us, but they're likely not experiencing quite a lot of this. And this is further work that one of my colleagues from Leicester is looking at what was the impact of CGM, on detection rates in the type 1 and type 2 population.
And while you're using consensus-based definitions for sensor-detected hypoglycemia in your study, you also report being designed to provide more of an evidence-based definition for sensor-detected hypoglycemia. Can you speculate for us on whether and what changes may be needed to our current consensus definitions based on the outcomes of your Hypo-METRICS study?
Yeah, so we actually had the pleasure of presenting some of this data at the ADA. So what the kind of primary objective was doing as part of the Hypo-METRIC project was really to look at kind of an optimization program to see what would be, the best threshold and duration which best matches, symptomatic hypoglycemia in the combined population. And we obviously looked at it in subpopulations as well. And what was interesting, and had the pleasure to train with Professor Stephanie Emile and work with Professor Heller from Sheffield, who I think were, in the room when some of these decisions were being made. The definition, actually, when we optimized it, came out very, very similar at about 3.9 millimoles per liter and 18 minutes. And I think the debate had always been, would it be 15 or would it be 20 minutes? So I think all the experts in the room kind of got it fairly right, which is probably not surprising given their experience. But really what the challenge is, even with that optimized definition, is that the, sensitivity is at 50% and the precision is really only at about 25%. So doing it on a population basis isn't probably going to improve the kind of numbers that we've shown with our consensus definition. But actually what we're looking to do, and what we've also shown as at ADA previously, is looking at actually optimizing the definition on an individualized basis. And so that's using the kind of Hypo-METRICS app data and the CGM and the matching to see, well, what is the optimum threshold for each individual? Because there's a lot of individual variation in our population. And what would be the best threshold? What would be the best duration for them, within some reasonable parameters? And particularly where that seems to be very effective is at nighttime, where you get quite high sensitivity, quite high specificity. And I'm sure, certainly my experience clinically in terms of alarming CGM, it's a fantastic resource to have, but it does impact people's quality of life. And anything that we could do to potentially reduce the number of false alarms, I think in this age of, I don't think you can go on a podcast without saying AI or precision medicine, but in this age of precision medicine and AI, to be able to potentially develop a individualized definition for each person living with diabetes to minimize those false alarms and maybe reduce the impact on their sleep without increasing their biological risk of hypoglycemia, I think is a really exciting potential outcome to come from this study.
Yeah, that's really terrific. And it makes me think about that less than 3.9 level 1. It's currently considered a warning threshold, but for some people, it really is very significant and can be very disruptive, whereas others, it can be extremely well tolerated and may be part of normal occurrences during various activities or brief periods overnight. Could be fine, but as you say, in some individuals and not for all. And so getting to an individualized, clinically meaningful threshold would be terrific. And finally, Patrick, what other takeaway messages do you have for our listeners?
Yeah, I think the big takeaway for me, I love medical history, and someone I always look to is William Osler. And to paraphrase him, he used to say, listen to the patient. They're telling you the diagnosis. And I often say to my own trainees as well, I treat patients, not numbers. And I think while CGM is a very valuable tool with very valuable metrics, I think what this data shows is it does not replace lived experience. A person can have a time below range of 0, 1%, but they can still be impacted by hypoglycemia, whether that's because they're experiencing individual events or because they might have fear of exercising or fear of hypoglycemia. So it's really, really important to not just look at a CGM trace and say, there's no problems here. I think the other really important take-home message is that, episodes of asymptomatic hypoglycemia on CGM are common, and they don't necessarily mean you have impaired awareness of hypoglycemia, and that this should be kind of tested with a validated measure as well with your patients. And I think in research, it's important that we consider, particularly when hypoglycemia is an important outcome in a study, what we're capturing. So should we be capturing sensor-detected hypoglycemia and person-reported hypoglycemia, because they have different biopsychosocial impacts? As another paper by one of my colleagues in this project showed, that it's the person-reported hypoglycemia which impacts the quality of life, not asymptomatic sensor-detected hypoglycemia. But that has very important biological effects. So I don't think you can look at one and not the other. I think you really have to capture both.
Really terrific message. Dr. Patrick Divilly, thank you so much for sharing your expertise with us today. I really appreciate all I've learned from your paper and our discussion on the relationship between sensor-detected and patient-reported hypoglycemia in individuals affected by both type 1 and insulin-treated type 2 diabetes. I encourage our listeners to access the full article in the October issue of Diabetes Care. Let's move on now to our rapid exchange segment, where Alice and I chat about some of the articles we found particularly interesting this month. Alice, why don't you kick us off?
So, Mike, it was particularly tough this month because there were so many good ones I could have selected. I'm going to go with the theme of prediction and prevention. My first pick is about a protein risk score to predict chronic kidney disease in people living with diabetes. Dr. Zhiliang Yi and colleagues with the senior author of Professor Xianhui Qin from Southern Medical University in Guangzhou, China, performed a cohort study of over 2,000 people living with diabetes with no history of CKD at baseline, who had proteomics and genetic information from the UK Biobank Pharma Proteomics Project. From a training set, they developed a CKD protein risk score, including 11 proteins. They compared the predictive performance of that CKD protein risk score with a validated clinical risk model from the CKD Prediction Consortium, as well as with the CKD polygenic risk score. After a median follow-up of 12.1 years, in which there were 112 CKD events among over 1,000 participants in the test set, the CKD protein risk score worked and was positively associated with incident CKD. Compared to a basic model, both the CKD protein risk score and the CKD Prediction Consortium risk model significantly improved the prediction performance. And when the CKD protein risk score was added to the CKD Prediction Consortium clinical risk model, the discrimination and reclassification of CKD was even better. So another tool towards more precise prediction, allowing for more personalized care, and the Star Trek future of medicine that I believe will happen.
Great pick, Alice, and so important to work towards earlier identification of disease processes so that future organ impairment, in this case kidney, can be prevented. My first pick is a randomized crossover trial of hybrid closed-loop insulin delivery for 6 weeks compared against sensor-augmented insulin pump therapy in individuals with type 2 diabetes. Dr. Anne Burrell from the University of Grenoble's Alps and colleagues in France enrolled 17 patients already being treated with an insulin pump and tested the Divilly automated Accu-Check Insight insulin delivery system, also known as DBLG1 system. This hybrid closed loop intervention improved time in range by 15 percentage points relative to sensor-augmented insulin pump therapy, as well as reduce glucose variability and improve measures of sleep quality obtained by actigraphy. These findings highlight that benefits of automated insulin delivery systems for glycemic control can extend from those with type 1 diabetes to also include those with insulin-dependent type 2 diabetes.
Great pick, Mike, because as you well said, this is technology that we certainly want to take advantage of more and more in the type 1 diabetes space, but why not amongst those living with type 2 diabetes? And it's all about reducing burden while still getting the efficacy that we're in fact looking for. So data like these are certainly encouraging that we can expand the use of technology to a broader group. So thanks for that. Now on to a mix of prediction and prevention, perhaps. Dr. Nuria Atta and colleagues, with Dr. Claire Meek from Leicester University in the UK, performed a systematic review and meta-analysis to see if high BMI and excessive gestational weight gain in women with type 1 diabetes are associated with perinatal outcomes. They included 29 studies involving nearly 19,000 pregnancies. They found that a 1 kilogram per meter squared increase in preconception BMI was associated with a 3% increase in perinatal complications. And having a preconception BMI of 25 plus was associated with a 22% increase in perinatal complications. As for gestational weight gain, a 1 kilogram increase was associated with an 11% increase in perinatal complications, and having excessive gestational weight gain, defined as weight gain above the threshold set by the Institute of Medicine, was associated with a 50% increase in perinatal complications. To be specific, preconception BMI was associated with congenital malformation, preeclampsia, and NICU admission. Excessive gestational weight gain was associated with preeclampsia, cesarean delivery, large for gestational age, and macrosomia. Therefore, beyond maternal hyperglycemia, preconception BMI and weight gain in pregnancy are modifiable risk factors and should be clinical priorities in pregnant women with type 1 diabetes.
Well, that is a tough one, Alice. It can be hard enough for some women with type 1 diabetes during preconception and gestation to achieve and maintain glycemic control targets without also worrying about weight and BMI targets. But on the other hand, knowing the risks involved with pregnancy and type 1 diabetes, I'm sure women will also appreciate the opportunity to further reduce risk through regulating weight as well as glucose. My next pick is a study examining the use of real-time continuous glucose monitoring, or CGM, for making insulin dosing decisions by hospitalized patients. Dr. Mindy Lee and colleagues from Stanford University in California enrolled 135 inpatients admitted using personal CGM to a hospital-wide protocol allowing for the use of sensor glucose in lieu of fingerstick blood glucose monitoring, with once or twice daily accuracy monitoring and electronic health record integration. Of more than 1,500 CGM validation attempts, 88% met criteria for continuing CGM-guided insulin dosing, with an overall mean absolute relative difference, or MARD, of 9.6%. In addition, 99% of CGM validation attempts fell within Clark error grid zones A and B, meaning even those that did not meet validation criteria would not have led to inappropriate treatment. And most important is that 80% of nurses preferred inpatient CGM to fingerstick blood glucose monitoring, as did 93% of the patients who liked the interactions with nursing staff over their CGM glucose and the control they had over their diabetes management. So the title of this article, which I love, is quite apt: Empowering Hospitalized Patients with Diabetes. And I hope the evidence presented helps us all move in that direction.
Completely agree. And I mean, we've had CGM for quite some time now, but there are very few institutions, hospitals, that are routinely allowing the use of CGM. And it's still quite archaic, even in the institutions that I work at. Even if someone chooses to wear their CGM, the nurses are not allowed to use that information. So they still got to go in and poke the person's finger, even though they've got a CGM on them, in order to be able to document it and put it in the EMR, et cetera, et cetera. So this is great. So I'm really hoping that this actually changes what the future will look like. My last pick is in the bucket of prevention and adds to the knowledge that what we do every day to address multi-risk factor control does actually pay off. We know this already from Steno-2, one of my favorite studies of all time, that multifactorial treatment makes a big difference in a lot of outcomes. Now we can add heart failure to the list. Dr. Jigui Huang and colleagues under the leadership of Professor Pinming Liu from Sun Yat-sen University in Guangzhou, China, performed a prospective cohort study of nearly 20,000 people diagnosed with type 2 diabetes and nearly 48,000 matched non-type 2 diabetes controls from the UK Biobank cohort to evaluate the impact of comprehensive risk factor control on heart failure risk and heart failure-free survival time in people with type 2 diabetes. The degree of comprehensive risk factor control was based on blood pressure, BMI, LDL, A1C, kidney function, smoking, diet, and physical activity. During a median follow-up of 12.3 years, 5.9% of people with type 2 diabetes and 2.9% of matched controls developed heart failure. Each additional risk factor controlled was associated with an average 19% lower risk of heart failure. Control of 6 or more risk factors was associated with a whopping 67% lower heart failure risk, with BMI being the primary attributable risk factor for heart failure. So people with type 2 diabetes had excess risk of heart failure, but this excess could be attenuated to non-type 2 diabetes levels when there was high attainment of risk factor control with longer heart failure-free survival time. So therefore, it works. Everything that we're doing all day long and trying to do, this multifactorial approach absolutely does work, and we can add heart failure to that list of why we do what we do.
Well, and Alice, this really exemplifies what is meant by cardiometabolic disease, the interplay of multiple risk factors associated with energy supply and demand that ultimately affecting heart health. But now, how about cerebro-cardiometabolic disease? Abigail Dove from the Karolinska Institute in Stockholm, Sweden, and colleagues analyzed data from over 30,000 individuals aged 40 to 70 years in the UK Biobank who had 1 or 2 brain MRI scans over an 11-year follow-up period, and used this to calculate brain age gap, defined as the MRI brain age minus an individual's chronological age. Both prediabetes and more significantly diabetes were associated with larger brain age gap, and this association was stronger in those with at least 2 additional cardiometabolic risk factors taken from the presence of obesity, hypertension, low HDL, and high triglyceride levels. Importantly, this effect was attenuated in those following healthy lifestyle practices. So it appears the brain as well as the heart is affected in those with cardiometabolic disease, and lifestyle interventions definitely matter.
So it's almost like it's one giant body, which it actually is, right? All the parts are connected, and what happens to one impacts the other. And even though in medicine we split off into different specialties, I think we really need to remember that it's still one person that we're treating and the impact that everything has with each other. And I got to say, when you're talking about brain age gap, I'm thinking, oh my, I wonder what mine is. I don't know if I want to know, but I wonder.
Negative.
Thanks, Mike, for giving us that one. So this takes us to the end of our October 2024 episode of Diabetes Care on Air. Big thank you to Professor Bu Yeap, Dr. Patrick Divilly for sharing their expertise with us. Remember that ADA has a special offer for new and renewing members with a 15% discount on 1 or 2 year memberships if you use the code FALL24 or FALL24 online at professional.diabetes.org/membership. This offer will expire on November 30th, 2024, and go for the 2 year. You get a t-shirt, and then you could be matching with Mike and I at the next conference. So take advantage of this great opportunity and tell your fellow diabetes groupies.
And remember, Diabetes Care is continuing to take submissions of original art for consideration to be included on a future journal cover. Please subscribe to get notifications about new episodes of this podcast, and thank you for listening.